All right, guys. Well, welcome back to the PCHC EMS podcast. We're going to be going over ECMO today and ECPR. We have our Assistant Medical Director, Dr. Bertrand, here with us, and we're just going to be going over some ECMO stuff.
So can y'all tell us somewhat about your backgrounds in ECMO and how you got into it and what's your interest in it?
Right. So, like they said, my name is Leal. I'm a cardiac surgeon currently at Fort Worth and in the Baylor system. I trained cardiac surgery, and then I did an extra year working at the University Medical Center in Dallas with Baylor. That's where I met Mario. And unfortunately, that was the time of the pandemic, So I've always had an interest in mechanical support and enjoyed working with the sick patients. And it was a very good learning experience. I think as a medical community, we all learn about ECMO, and it kind of slingshot the ECMO technology and what we can do quite a bit, I believe. So once I finished that training, I moved to Fort Worth and been helping ramp up the ECMO program at Baylor All Saints. We started the ECPR program as well as our LVAD program, and continue to work together with. It's a neat community of physicians, because it doesn't matter what hospital they work in. It's very collegial when it comes to ECMO. Everybody just wants to have good outcomes and help as many people as possible. So that's one of the things I really enjoy about it.
Yeah, so my name is Mario Padilla. I'm a nurse practitioner at Baylor downtown Dallas, and I've been doing ECMO since 2010. So really since we started our ECMO program at BUMC. I started out as a nurse, and I've always been in cardiac surgery actually since going on 20 years now. You can probably do the math from there, but yeah, going on 20 years. And I've done a little bit of, ER and cath lab, so I've had some exposure, everything that's kind of come together with ECMO. So we've developed our program. We're a gold center, a platinum center was our last redesignation certificate we got awarded by ELSO, which is the organization that oversees ECMO programs, or any center that is recognized by for their ECMO outcomes goes through ELSO. And I slowly worked my way up, done into primary roles as an ECMO specialist, into doing transports. We were doing the first transports for patients that we were putting on ECMO out in other facilities, and I would go out and be when Dr. Leal came on, I was, you ready to go? We're gonna get rolling. Literally walk into any facility, not know who is who, and could walk anyone through on how to put somebody on ECMO. But there's putting them on ECMO, and then there's managing, which is two totally different things. So we would put them on, and then we'd bring them back to Baylor.
Sure.
So here, it's been a solid year since we've actually officially identified, or we officially have ECMO dedicated ICU that's strictly ECMO patients only. And along with our chief and medical director, I help manage all the patients, and so help partake in identifying, evaluation, to initiation, to removing a patient from ECMO, and even seeing the patient on an outpatient follow-up too as well, so that they don't just fall through the cracks.
Yeah.
And I completely agree with. I'll just echo what Dr. Leal said. I think anything that's going to help improve outcomes, I'm all for. So call for help. I think we're going to help out. We'll find one way to help out each other or another for better outcomes.
Great. Well, like Jeff said, we don't have a whole lot of experience with ECMO, but Best EMS, and coupled with our agencies like Parker County, we are all about improving outcomes and being aggressive if that aggressivity has improved outcomes. And we're seeing that ECPR looks like it will have those outcomes. And so we know, coupled with the basics of resuscitation, which is compressions and defibrillation, the only things that have been shown to increase your survivability in cardiac arrest are those two things. And so for us, this is kind of a mindset change, because there's nothing in the hospital that our MICU units cannot do in the field with regards to resuscitating a patient. So our protocols call for them to stay in the field and resuscitate as long as it takes to either reach that point of getting Ross back or reaching that point of calling it as termination. So moving into ECMO field, it's a big change for us because now we're telling our crews, once you get things identified and you have your high performance CPR going and it's a patient that meets our inclusion criteria, then we need to get that patient, in the back of the unit and get going to the closest ECMO center. So our inclusion criteria call for a witness cardiac arrest, the initial rhythm being VT or VF, and I've had some questions from medics about, well, what if the initial rhythm was VT or VF, or we get there and they got defibrillated by an AED, but now they're in asystole. Well, we still transport those patients, right? Because the initial rhythm was VT or VF. So we still want those. Our age range is 18 to 65. It seems like there's so many agencies that have different age ranges. Some of them go up to 75. Some of them stop at age 50. So it looks like once you get above 75 or so, then the results are less promising. And then we want to be within 45 minutes from the arrest to the facility, right? Because it seems like that 60-minute mark of getting somebody on the ECMO device is crucial. And we want them to have had bystander CPR, so less than 5 minutes of no flow. So if we have somebody who's been down for longer than that with no CPR, then they're excluded. And then our other exclusion criteria are traumatic arrest, dialysis patients, anyone with a terminal illness or a DNR.
So I would start for the people that don't know much about ECMO. I'll explain what ECMO is. Sure. And then as we progress, we'll go into the details and how much EMS can help us. Because honestly, I think the biggest part of the entire ECPR is the EMS system. Okay? Our job is made a lot easier by you guys' help, to be honest. So I'll start with ECMO. And ECMO just, it means, it's an abbreviation for extracorporeal member oxygenation. And it's derived from the cardiopulmonary bypass that we normally use for heart-lung machine for cardiac surgery. It's been used since the 1970s. And what it is that it pretty much is a oxygenating membrane, which I think about is anybody that's seen a fish tank, the machine that makes the bubbles, just circulates the water or the blood, gets rid of the carbon dioxide and inserts oxygen so that the blood gets oxygenated again. So that's what pretty much ECMO is. And there's two forms of it. When you hear about it is venous and venous arterial. And what it means is venous, you think about it as just bypassing the lungs. So it was very common to use VV in short term is for COVID patients or patients that had ARDS or aspiration pneumonias. So that's what we use. It just bypasses the lungs. So you assume the heart function is normal. Now VA is completely different in that it bypasses the lungs and the heart. So that's where you put in your drainage in the venous system and it oxygenates, gets rid of the CO2 and returns it into the arterial system. So that's sort of the two things that we're talking about. And like I said, as a surgeon at the beginning, I was just like, well, I always hear about this history and all that stuff, and we probably don't need it. And then once you start doing it, you realize how complex it was. So you want to pay some homage to the people that came before you, But so the heart-lung machine was started in 1954 by a guy named, it was Dr. John Gibbon. And then ECMO, the father of ECMO is Dr. Bartlett. And that started about neonatal ECMO was started by 1972. So those were really pioneers. The first successful ECMO used on an adult patient was in 1972, and then in 1975 they used it on a neonate with meconium aspiration. So, and since then we've made such a big advance in the ECMO technology that there's no absolute guidelines of when you use ECMO. But there's this society called ELSA that was created in 1989 that helped us. It means Extracorporeal Life Support Organization that was founded in 1989. And it gives a kind of overall some guidance on what to do and when to do it. And like we saw in COVID, the other big push that we have for ECMO happened in 2009 with the flu pandemic and N1H1. And so that's where the WHO kind of realized that this is a technology that we can use and have some good outcomes. So since that pandemic, the H1N1, there's been a lot of increase and push into researching more about what can we do, how can we do it, how can we be more efficient, how can we have better outcomes. So there's a big trial that happened in 2009. It's called the CSAR trial. That it showed that increased survival on patients that had ECMO and the flu. So that kind of like slingshot everything again. You know, we have those technologies that started in the 70s, and then it kind of was dormant. Some people were doing it, not very much. H1N1 happened, and we realized that we have this technology stored and not being overly utilized, and we saw the good outcomes. So since then, it's been pushed, and I think after COVID, it just exponentially increased the use of it.
Can I ask you a question?
Yeah.
So in someone with influenza or any other viral pneumonia, COVID, whatever it be, and they have respiratory failure and they're on a ventilator, are all of those people candidates for ECMO, or do you have certain criteria that they're maxed out on?
Yeah, so whenever there's a criteria, unfortunately, in those scenarios with the pandemics, that the pandemic is a completely different scenario than before because we have limited resources, right? So criteria happens and we become more strict as the need increases because we have to make sure that we cater to the people that are going to have the best outcome and survive, right? And it's one of the toughest decisions you have to do as a medical professional. But yeah, we try to pick people that are for flu, they're on less than 65, less than 70, single organ damage. Okay. We want to make sure that they're pretty healthy otherwise, because it's a lot easier to deal with the lungs failing, one thing failing, versus when you have your kidneys failing, your liver failing, your blood levels. So there's certain criterias, and every institution has different criterias, and it's just based on, one, I think, is the amount of resources they have, and number two is the comfort level from the ICU team and the medical professionals taking care of them.
And so when you go to select those patients, not to be confused with, you're cherry picking.
Yeah.
You're putting patients on that are going to come off who never needed ECMO. But if you look at the criteria, you look at their x-rays, you look at their CT scans, their lungs are damaged.
Yeah.
I mean, beyond recognition in some of the patients. Mm-hmm. Their PF ratios, if you understand, their PF ratios are less than 100. Mm-hmm. Prone,
severe ARDS.
Just severe ARDS. And single organ failure, especially when you had the number of patients that went through, and COVID I felt like it came in spurts where it was like it was affecting lungs, and it's affecting the kidneys, and it's affecting the lungs, heart, and kidneys, so you get into multi-organ failure. So you go to put these patients on, the centers are like, okay, this center's doing it, I want to do it. Well, you go to put these patients on, then you find yourself in a hole with a patient with multi-organ. So is identifying those patients appropriately, and of course utilizing your resources appropriately, because then before you know it, your institution's out of beds. Mm-hmm. And not just for the flu or H1N1 patient, but your everyday ER patient that's going to come through is now your ER's being a bottleneck and backed up.
All right.
But I think that's where the criteria comes into play. You kind of have to rapid triage like you would in the field in a mass casualty scenario.
Yeah. I'm assuming when you put somebody on ECMO, it's not a quick process to put them on and then take them back off.
And that was something that was different that we saw influenza versus COVID. You know, the influenza patient or the ARDS for aspiration, those are what we call short runs. So they usually get better within 10 days. Okay. COVID, there were very long treatments. The way that the virus affected the lung tissue was completely different than something that we had seen before. So the ECMO runs, it was not unusual to be 2-3 months.
Oh, wow.
So thinking about, that's why we had the criteria, because we only, even the big institutions, we have 6, 8, 10 machines,
Right.
you know, and knowing that if you put somebody on it, it's gonna stay on for about 3 months. So for 3 months, that machine
Yeah.
is completely out of like you can't put anybody else. So that's one of the challenges. So normally we say if it's a VA ECMO, it usually runs less than 10 days. After 10 days, the survival kind of decreases and it kind of is like it's self-determined. But the VV, you can keep them for a long time. The longest we had, it was close to 6 months.
Yeah, 187 days, I think, was.
Oh, wow.
So
But that was survivor? No?
Well, didn't discharge from the hospital, but yes.
Okay, discharge.
Survived the ECMO.
Yes.
Yeah.
Okay.
But I mean, obviously, the shorter the run,
Yeah.
the easier the body recovers. But so those are some of the things that we had to deal with. So we learned a lot about ECMO during those times because we were going over the limit of the time that previously patients have
Yeah.
gone. You know.
Yeah. It was all uncharted territory.
Yeah, I haven't seen that many patients being kept for 3 months,
Yeah.
4 months, and that was pretty much the usual now.
Yeah.
Oxygenator. So the components of the ECMO machine are there's the membrane oxygenator, there's a centrifugal pump that has to pump the blood and drain the blood and pump it, and then you have cannulas. You also, you know, those patients, sometimes you need to cool them, you need to warm them, so it has a heater, and one of the advantages is in the case that the kidneys start failing or they are fluid overloaded, you have specific connections that you can put them on, and you can do dialysis through the ECMO circuit. So, and so those are the pretty much the components of the ECMO circuit. It's a very portable machine. It has decreased in size. If you see the pictures from like 1970, they were the size of the actual heart lung machine they use in cardiac surgery, and now they're transportable. They're about the size of a a big box.
Carry-on suitcase.
Yeah.
Yeah, so,
Carry on, yeah.
yeah.
And when you're cannulating these vessels, are you using ultrasound or anything for confirmation, or you're just going?
So we have a system, and it was the way that I learned is the way that Mario and the guys at Bumpsy have been doing it, and we try to use ultrasound as much as possible because it has decreased the risk of complication, injury, and direct injury to the vessels. So we use ultrasound and cannulate by putting a wire, kind of the same procedure that you would do a central line, Seldinger technique, needle, wire, and then dilating, and then you put the cannulas in. Now, big other centers, I know they like to have echocardiogram available, and they have to get like a image by
Or
fluoroscopy. But we've done hundreds of patients now, and we feel very comfortable doing it blindly with the cannulas. But the biggest complication is growing complications, and they're greatly avoided by using ultrasound.
Yeah. And if you have a patient from EMS coming to the emergency department, how long does the procedure take from the time that you walk in there to getting them on the pump and feeling like, okay, we're on?
So, I mean, if how it works here, and I live in Parker County, so I'm very interested for you guys to be good at it because I live here.
Yes.
But so you guys notify us. So when you guys identify, and this is why it's so important for EMS to be our partners, is that you guys identify, say, I might have a guy that will benefit or a girl that might benefit from ECPR. So the alert goes to all the team members, or ECMO specialists are in-house. The surgeons live about 10-15 minutes away. So we start heading over. By the time that we get there, the patient is quickly assessed by the the emergency room doctor, confirms that it will be a good candidate for ECMO based on the criteria that we'll mention here in a second. And the process is fairly quick. I would say once the patient is in the trauma bay to the we're on pump is usually about 15 minutes.
Okay. Interesting.
So that's where our 45 minutes comes from, is because we're trying to keep it beneath an hour for
Yeah.
arrest.
I would say even as you work on it and develop it and really improve tightening up your times, the process, you can even shave off, minutes. Somebody doesn't think 1 or 2, 3 minutes count, but they do when you're on the clock. So I would even push back, the notification time to dispatch. If dispatch, when you communicate with dispatch a cardiac witness arrest, at that point, dispatch can already contact, okay, well, this is going to be your ECPR center. Similar to us, of course, practice dictates that you would go to your nearest center. I think in this case, with ECMO and ECPR being available, similar to a stroke, you have a patient who has a stroke, well, you need to go to a stroke center. You have a patient who has cardiac arrest, viable candidate for ECPR, then, at that point you would redirect to your closest ECPR center. And then that's going to alert the team whether, we're good to go and you guys confirm, then the team is going to meet you in the ER. And even some of the patients where I know where we've gotten really, really good, we're, door to ECMO to cath lab in some instances in less than 15 minutes.
Oh,
And
wow.
the outcome is, drastically, like it's notable, it's a win for everybody, but a big win for the patient. So for sure.
So
And that's one of the areas that is an area of improvement for us, because just coming into this, we have been relying on our responding medics to make the determination if the patient meets criteria. One of the things in reading more about this is that it really needs to start with dispatch. And especially here in a place that's such a vast county, because it can be dispatch, on the phone with the bystander, coaching them through CPR for 7, 8, 9 minutes before, medics arrive. And so I think we'll have to roll that back to, we need dispatch to start trying to assess if the patient meets criteria while they're talking to the bystanders doing CPR.
Absolutely.
We can definitely shave some minutes off of that.
Absolutely.
Then, once the medics arrive, they can immediately know it's a candidate.
put a blurb in the notes for us as we're responding. Hey,
Yeah.
possible ECPR candidate.
Yeah.
I'm going to show my ignorance real quick. So, what if I'm transporting to an ECMO center and I've already made the alert, and then I get ROSC? Does that affect anything?
Keep coming.
So, go ahead.
Yeah, I would say just if you already made the call, you've already alerted the team, you got ROSC, great for the patient. What are the chances if in some of the literature where you look up to these patients that have VTAC, VFib, initial rhythm, there's the culprit tends to be some sort of a coronary lesion. Yeah, you got ROSC, but also the chance of refractory VT-VF are also probably just as high, maybe over 50%. And that happens. It happens. You show up, oh, we got ROSC, great. I'm like, hey, good job, excellent CPR, you guys did great. And then you guys turn around and leave, and guess what? They go right back into VT-VF. Not uncommon for that to happen, back and forth. And we figured out, well, we're no longer going to scratch our heads about it. Let's just put them on ECMO and go ahead and, go after, activate at that point, whether it's a non-STEMI or STEMI, activate the cath lab too as well.
And that's some of the things that we have talked about before. Our preference is for you to get ROSC, okay? Continue doing the good compressions, the same ACLS that you have to do. And if you get them and we come in, and the entire team is always happy to be there, your success is our success. So it doesn't matter if you get ROSC, just continue doing during transport the same things that you've done for a long time, the good compressions, the medications. And then once we get them, we can evaluate and see, well, maybe we'll stop the epi at this point, if we're going to go on ECMO but that's, the compressions and stuff with the Lucas. But for you guys doing transport, keep doing what you've been doing a great job at with the good compressions, the medications. And if you get ROSC, that's a success. But we'll be on board and following because of those refractory patients.
Okay.
And some centers, once you get the patient on ECMO, and before going to the cath lab or ICU, some centers are passing the patient through CT. What is y'all's practice?
So we would like to go through the CT scan. And there's a couple of things that we looked at. Number one of the biggest things that can happen, and is that they might have either a brain bleed or a big stroke. Okay, so we want to know right up front if something devastating happened, because you can get cardiac function, but if the inciting event was a huge stroke, then you want to know that. You want to know that your cannulas are in a good position. You want to make sure there's no retroperitoneal hematoma. There's no other things that you might miss as well. Now CT scans in the ER in particular are so streamlined that it probably adds maybe another 5-7 minutes before the patient goes to the ICU or the cath lab, and it gives a broad. It gives us a lot of information that might be useful in the long term.
And then just to add on to that, another big, that's come out from having the CT scans done is the CTA.
Yeah.
So a pulmonary embolism, a massive pulmonary embolism, a saddle embolism, that's something that is we've been able to identify. You think, you see elevated troponin, BNP, maybe you see some ST, EKG changes, so you automatically go to STEMI. Well, yeah, there's it's hypoxia, lack of oxygen driven, so the tissue's taking some damage. And when you go to do the CT scan, you see the massive saddle pulmonary embolism. So at that point, even more, just to add on to the streamline, the cath lab's already activated, but now they're setting up for a mechanical thrombectomy as opposed to a PCI, because now the tools vary by little, but when they already know, okay, this is the culprit, this is the issue, then it just streamlines their care to
So
get
it
them
helps.
through.
It helps a lot.
Yeah,
having
it does. It helps a lot.
Yeah. Okay.
And in these situations that we're talking about, just so I'm on the same page, it's always going to be VA ECMO when we're becoming
And ECPR, yes, sir.
ECPR is
Yeah.
always going to be VA ECMO.
Yes, correct.
Okay.
Mhm.
And then I've had some people ask me, what is the difference between ECMO and if my grandfather goes in for a bypass operation? How similar is that?
So ECMO is designed, if you want to go into the nitty gritty of it, ECMO came from the bypass machine, okay? When you're doing heart surgery, you're using 40,000 units of heparin, okay? Because you want the blood as thin as possible, because you have a reservoir. So you drain the patient's blood into a reservoir, so you don't want that to be coagulated. On the ECMO, it's a closed circuit.
Okay.
So you're able to have a much lower dose of heparin because you don't have a reservoir. You don't have stagnant blood. It continues. So by having it that way, ECMO is able to be run much longer and safer than a cardiopulmonary bypass. So the technology first was a cardiopulmonary bypass machine, and then it's pretty much, you took all the unnecessary parts that you're not going to use for doing open heart surgery, and it's a continuous loop. Okay. It's a closed circuit.
Okay. And then you mentioned earlier, once you have the patient in the ER, determining your criteria, is that different from EMS's criteria or not?
So as far as our criteria is going to line up, because we're going to be on the same page. When we're working together, first of all, we're going to be we're going to make sure that we're reading from the same book. Nobody's getting their checklist crossed. But I think one of the big things when you do show up and we have this patient in cardiac arrest, as you'd mentioned and emphasized, is the high quality CPR. I think one of the things that's really come about that's helping out is the automated chest compression devices, or Lucas, not to be promoting one or another, but I think a lot of folks are familiar with Lucas, that, automated, that frees up some of your man to, reorient and place another line if they have to, be able to give drugs or record or whatever else they have to do. The other big key factor is going to be that we are very strict about is witnessed, and meaning that you arrived on scene, talking to the patient, and the patient just went, syncopal event. They went into arrest right in front of you.
So it needs to be a provider witness.
I would say that's preferred. Yeah.
Yeah, and sometimes, depends on, we try to be as accommodating and help as many people as we can. But as you know, when somebody, especially somebody that's dear to you, passes out and has a cardiac arrest, time goes by a lot faster than you realize. You know, he's like, hey, I was just talking to them, and it's been only like 2 minutes. When you analyze everything with the stress and everything, it's probably about 7, 8, 10 minutes. And who knows if you were where you were at and how prepared that patient is, or the family member or the witness is to do good compressions, to call 911. And so then you start adding a lot of unknown factors that bite into that time, and that's where we can get cardiac arrest, but we don't know about what the mental status is going to be, the hypoxic issue that's going to be. So that's why we have that criteria. I mean, we try to be as accommodating as we can, especially with young patients. You know?
Yeah, I was going to say, I would imagine age plays a big factor in that.
It does. I mean, I think, you know, you hate to hear, you know, somebody in their teens or their 20s, you know, young, family. I think if anything else, for as much as we have available and for what we do for our community, you know, those patients really deserve a chance. And it could be one of those things where, you know, again, going back where you're going upstream to dispatch, and dispatch could have been on the phone with the patient calling in shortness of, you know, my chest hurts, some difficulty breathing. Then they all of a sudden stop speaking, but somebody's there to pick up the phone or just start CPR. I mean, that, you know, that could be documented time too as well that we would take into account.
We know exactly. We know exactly when they lost
Right,
consciousness.
right.
Yeah,
Mhm.
we've had a few of those fairly recently, actually.
Yeah.
Yeah.
And so that, I think that as long as we're all on the same page and we see eye to eye, then, you know, better outcomes are going to be, hopefully, you know, one can't predict it. If one could, we could, but it's going to be in our favor for a better outcome for everybody.
And that could be something that we work with our dispatchers and, you know, to get like an actual timestamp in the notes of the call that we can pass on to you guys. Hey, at this time, they were talking and they stopped talking. So you guys
Right.
have an exact, like if you're considering ECMO,
Right.
we know this is when the cardiac arrest probably started.
Yeah.
And the guidelines are there for a reason, you know, but it's not like, oh, you guys set 45 minutes and it's going to take 47 and we're not going to do it.
Sure.
Obviously, I mean, we try to work together, and we have the same goal as to save many people as possible. So that's why overly to communicate with you guys, and you guys are the most important partnership that we can have, is good communication with you guys when they give us report. We like for the EMS crew to stay around. Once we go on ECMO or we decide not to go, but then we debrief and how we can make things better for you guys, and then things that you could have done, or, you know, we grow together as a system and
Right.
as a group.
Yeah.
You know?
And I think something that from a paramedic's perspective, it can be frustrating for us. You know, we get there and we're like, oh, this might be an ECMO candidate. This might be an ECPR. Like, we're going to save this person. And then for whatever reason, one of those contraindications, it's like, hey, this one's not actually a good candidate for ECMO. We're not going to do it. It could be frustrating for us, but from y'all's perspective and from what you guys are doing, you're protecting a really important resource that actually is absolutely necessary to be available to somebody who's truly like could benefit and survive. And
to that point, that's why I want the EMS crew to stay and participate in the debriefing, because, man, I mean, I know you guys are so invested in trying to save that patient, but then when we see them and the lactic acid is like over 25 and you know, the CO2 is high, so there's signs of hypoxic injury and malperfusion, but it's a good thing we celebrate our successes together. You know, we're pretty good at trying to get back with the AMS and be like, hey, remember that guy you guys dropped and all that? He walked out of the hospital,
Right.
You know, because I want you guys to see that as well, and not just, oh, they went on ECMO and I don't know what else happened, you know. So, and then when the patient's not a candidate, we talked about why he's not a candidate.
Right.
It's not like we just say, oh, no, he's not because it's not convenient or anything like that. No, we want to make sure that we do everything we can and also keep you guys involved, because there's so much effort from your standpoint, physically, emotionally, to get those patients through, that I want you guys to be part of the team and feel very validated, because we can't do anything that we do without you guys' help. So
Kind of highlight the 4 important factors of all ECPR, ECMO, EMS, the 2 crews, everybody just coming in together. Imagine yourself having a checklist. Dispatch has, with dispatch getting the call, they have their checklist of screening a patient for ECPR. Cardiac arrest automatically just get checklists out. They'll start going through. And so far they're checking at the box. You arrive, check, check, check. And then once those 4 boxes are checked, your ECMO center has already been put on alert. So high quality CPR, early intervention, early arrival, and scooping and running for lack of a better term, not to say that we're just picking up a patient, but being able to get to that center within that time frame. I understand rural areas can, be difficult. I know that. I grew up in a rural area. But I think, we're, working to where our team is mobile through via a helicopter, rotor wing. And if it's something where we can load and go ourselves and meet you at a neutral area in, 15 minutes and meet up, I mean, that's something that, we're not too far from that future. And that's totally something that we could work together on and capitalize on. But one of the things that, I also emphasize is again, it's going to sound like a broken record, but is identification of your rhythms. EMS, I mean, you guys see, and I worked from the short stint in 3 years that I worked in the ER. I mean, I know you guys see strips after strips after strips after strips, really, really being comfortable with a rhythm, cardiac rhythm identification, really knowing that. And it sounds silly, but it really can make a difference is identifying your strip, VTVF been known to have the best survival outcome. If that's your initial rhythm, first initial documented rhythm, that's what it is. You shock them and they go into asystole. Your first initial documented rhythm is VTVF. Keep going, and as you go into PEA or asystole, you show up to those rhythms tend to carry lower mortalities. Not an absolute contraindication, because it could be that young person that, for some reason maybe has a history of cardiac disease and has an established physician. And sometimes they show up in our system, this is a patient who's been seen. Well, we have an idea of what's going on. Let's continue to go forward. CPR, the time, that again is going to make the big difference. The longer the time goes, I mean, after about 20, 30 minutes, the curve, the falling off the cliff, for lack of a better term, is pretty steep, So we like to say, 60 minutes is kind of like the standard guideline for any reputable ECPR center, but that's total time from, the call of dispatch, so when the patient collapsed to, being able to get that patient on ECMO. And sometimes there's overlap. I'll be honest and I'll be wrong, where I would question myself, well, we just went too far. The patient was down too long. Oh my gosh, now we're going to have to go through the process of, what's going on, anoxic injury and more devastating hope to the family. And for some reason, the patients are not. There is outliers, but we try to avoid that as much as possible. We don't want to instill false hope into anybody, but time is a big difference. And as you can tell, I mean, we spoke of a couple of centers. Albuquerque, New Mexico, University of Minnesota is another huge ECPR center, and then again, they just go into the relationship of CPR and survival. And I keep harping on that because that's what's going to, your quality CPR, your early, just being on top of it and getting to the center is really going to have the biggest effect on the patient's outcome. And as they get to that 20, 30 minute mark, the mortality continues to increase from there. These patients that go into VTVF, I think it's been shown that, a good chunk of them, 70, 80%, tends to be coronary, ACS syndrome. So for those, as much as we like to say quick, easy fix, going to a good center, it seems like a quick, easy fix, right? Historically, those patients that went into VTVF or had refractory, I mean, their mortality was really, really high, way over 80%. And now we've been able to half that death mortality percentage just with the use of ECPR and the use of team collaboration with EMS.
So the big team is the EMS, the heart surgeons, cardiologists, critical care. So that's why we partner up with a cardiologist. You have to make sure that they're all on board and excited about this as well.
Yeah.
Because we can put them on ECMO, but we need to reverse the underlying cause.
Mhm.
And they're an invaluable team member as well.
Yeah, certainly.
Well, that's one thing that I was obviously, leading up to this, I've tried to do a little bit of research and like educate myself on ECMO. And one thing that was summarized pretty well is, a Lucas device might achieve an ejection fraction of 35%, and VA ECMO is 100%, right? I mean, like it's completely perfusing the patient. So
Yes.
any problem that is related to the heart or lungs pretty much fixes it immediately. So
Yes. ECMO can definitely support. I mean, ECMO has its, 20 to it as well. It's not designed for long term. Anytime we have somebody on VA support or we put them on, we're already thinking in our heads
When is he gonna come on?
what's going to be our exit strategy.
Yeah.
And this is where it's great to have somebody like Dr. Leal. I mean, he can get very creative between all of us on how we're gonna get this patient off ECMO. I mean, I've had a patient that we've had on ECMO 24, 48 hours, and I'm like, all right, I know what we need to do. Let's get this patient off ECMO, because the longer you leave them, I mean, you do prolong the patient to other conditions.
sure,
Such as hemolysis, thrombocytopenia. You're chewing up the red blood cells, you're chewing up the platelet count.
Yeah.
They're on anticoagulants, so the risk for head bleed is there.
Limb ischemia, gut
Yeah.
ischemia, liver
Yeah.
failure. So that's what we're saying. Like if it's a VA, you can't have 10 days. After 10 days,
Mhm.
you need to start coming up pretty
Okay.
soon before something else happens.
And so I think the next step in ECPR is going to be kind of what you touched on, is trying to bring it from the hospital to the field is where it's going to be needed. Because you mentioned you live here in Parker County, you grew up in a rural area, I grew up in a rural area, Jeff lives in a rural area now basically, and we want our survivability to be, I hate to use the word fair because life's not fair, but fair for everyone, right? If I go into cardiac arrest right now, or at my house, or you in your yard, we want your chances of survivability to be the same as if you would have had your cardiac arrest while you were in the parking lot at your hospital.
absolutely.
And it's just I don't know if we'll ever get there, but that's what we strive for, right? Is that if I have a cardiac arrest in Weatherford versus Little Rock versus downtown Dallas, I want to have the same chance of survival from that. And there are some centers that are bringing it out into the field. It's a huge challenge, as we can imagine, but I think that's where we're going to have to be headed, at least for, the vast majority of our country, which is rural.
Right. And I think that's a big difference. I'm not an expert, obviously, but the big in the field ECMO centers and stuff has been mainly in Europe.
Mm-hmm.
Europe is much smaller than
Yeah.
just Texas. You know what I mean?
Right.
So in our population, there's a big distance.
Yeah.
If you compare DFW, I think what I expect in the future is going to be the hub and the wheel and the spokes kind of model. So you have a hospital right across from this building, right? It's small. It probably won't be able to take care of the ECMO, but maybe you have the option in the future, once this becomes more mainstream,
Mm-hmm.
that you can take into that EMS to that ER. The patient gets cannulated, shipped immediately to a center that can
Manage.
identify the cost and manage it.
Yeah.
So I think the U.S. and we're moving into having a lot smaller hospitals versus and then the transport into
Yeah.
the big centers.
Mm-hmm.
And as time goes by and this becomes more mainstream, there's more people that know about this, and the skills for the people doing it are built. Maybe that's one of the solutions that we might have, and that's where EMS and the transports, helicopter, and all that stuff will come in.
Yeah, because, being one of the few things in the last 60 years that has been shown to improve your survivability from cardiac arrest, we really, need to try and get it out to our patients, because it's so crucial in the time frame to get them on.
And you're seeing an increased interest in developing programs,
Yeah.
and that's another thing. It's kind of special, and that's what I like, is that I have friends in different hospital systems, and I know that I can pick up the phone and ask for help, and they'll come in if we're full. Again,
Yeah.
it's a community, especially that we're trying to make sure that we can reach out as many patients as possible,
Yeah.
so that we can increase
Yeah.
our success. So it goes beyond the hospital affiliation. It goes beyond
Oh,
everything.
yeah.
It's just we just want to make sure that we are working together as a community to help those people.
Yeah.
You know, so if there's centers that we're interested in opening this program, we're happy to go in. We're happy to go show them how we do it. You know,
Right.
because that might be my dad, my mom that might need it. You know,
Right.
so I'm happy to
Yeah.
share our knowledge, and we're there to back them up as well.
Yeah.
If they say, well, we got this patient on ECMO, we need help getting them off.
Yeah.
And then that's when we come in, transfer them in as well.
Yeah.
So I think that's what might happen in the future.
Yeah. Hopefully so.
Is ECMO getting more portable? I mean, I know you guys said it used to be these giant machines, but is it still getting more portable, or is it about as good as it gets?
Well, you have to have it. I think it's pretty portable. You know, if you think about it, is that those patients are pretty sick. The ECMO machine is probably one of the smallest things that it's heavy, but it's small. That you're moving, but you're transferring the patient. They're on a ventilator. They're on the drips. I think I'd
a
rather
process.
transport the ECMO itself than all those pumps.
Sure.
Do you know what
Yeah,
I mean?
absolutely.
Those pumps are more cumbersome than the ECMO itself.
My only experience really transporting ECMO, it was a fixed wing flight. The ECMO team was on an airplane with the patient. They got in our ambulance, and we plugged it into the ambulance, and for some reason it wasn't charging. This was at a different service many years ago, and our ambulance, I guess, couldn't put out enough power to power the ECMO machine. And so I'm like, okay, I asked the perfusionist or whoever was riding, how long does your battery last? And he's like, well, it lasts about 45 minutes. Cool, we're only 15 minutes away from the hospital. 5 minutes later, the battery just died. The ECMO machine stopped. I don't know if it was VV or VA, but I know that he very quickly pulled out a hand pump and handed it to me and told me, keep it in the green. And I'm like looking at it, and I'm trying to crank it. I did a terrible job. I'm pretty sure I never got past orange or yellow or whatever it was. And he's like, no, you got to go faster. That thing was like really difficult to pump.
Yeah, it's heavy.
Finally, he snatched it from me and just did it himself and got it in the green the whole way. And I guess it did fine, but that was really my only experience transporting it, and it terrified me because I'm like, oh my gosh, I have no idea how to operate this thing.
Well, and it's interesting because the agencies that I've looked into that are doing ECMO in the field, it sounds like they're all using the hand pumps. Yeah, they're all using the hand pumps. But it was a Herculean effort in the Netherlands. They have, I don't know if you looked at their service, but they have 4 helicopter teams basically, and they trained like 52 physicians to be on the teams. But their goal is that everyone in the Netherlands will get ECMO if they meet criteria. There's no area that they won't.
You're right on point. I mean, you have this happening over clear halfway across the world.
Yeah,
Infrastructure is going to be key,
yeah,
and you got to have buy-in from, I guess not just EMS, but even the city. The city's going to have to buy into this too as well.
The money's got to come from somewhere.
It does, because you have to have, when you want to come in and collaborate with the center for EMS to provide ECPR patients. I mean, it's like anything else. No one can predict when it's going to come, but when it comes, you have to have a team dedicated and ready to go.
yeah,
And ready to go. And I mean, to the point to where we would like to even have your team sitting at our facility at one of our ambulance bays, ready to go with our team ready to go. I mean, you're not sitting there by yourselves just twiddling your thumbs, although that may seem what you're doing, but until that call comes in, there is no delay on the team, whether it be by ground or by air. Yeah. And I think that's where the Netherlands is at right now. They definitely got to step up on everybody.
Yeah.
And I'll share with you guys, since we're talking about ECMO and ECPR, just because I'm sit on our little planning committee. I say little planning committee, but our planning committee for our facility, where we're actually going to have a ECMO symposium. It's a system-wide ECMO symposium that accounts for all Baylors, and then we're also going to have some keynote speakers from other facilities.
Okay.
In addition to a keynote speaker from University of Minnesota, Dr. Yiannopoulos, who is,
Yeah.
he'll be there,
He's
and
the-
then
he's the guy.
so
Yeah.
he's going to come in. So
What is this?
June 1st and June 2nd
Of this year?
of
Okay.
this year, yes, sir. Yeah, and I think
Okay.
it'll be a good time. I mean, you'll be able to get it all in from beginning to end to the quirks. I call there's a section in there like the aftermath of ECMO.
Okay.
Because you have, that's something that we're accounting for. We have this
Yeah.
outpatient ECMO clinic. Dr. Leal has actually referred a couple of patients to us from Fort Worth, but what happens after? So,
Right. I can't imagine the recovery.
I think I had a patient say that their PCP dropped or fired them or dropped them because they had accumulated too many comorbidities during that hospital stay that they did not know how to manage them.
Yeah, they were just uncomfortable.
So, we don't want them to fall off. We want to be able to help see them through.
And
So the symposium is open to anyone, or?
It's gonna. We do have a registration site that's gonna
Okay.
be open to docs, EMS crews, students, nurses, APPs. Whenever he's actually going to be speaking, and this may touch a lot of folks or may feel some folks sensitive. Is pregnancy and ECMO. It happens. You get the girl that you go and pick up who's having placenta previa or
Yeah.
or pulmonary embolism from.
amniotic fluid.
Yeah.
So at Baylor, also there's Andrews Women's Hospital. So a little background: when my wife was pregnant, I was freaking out about everything. So I wanted to make sure that we had the ECPR going, that everything was set up, and we've actually had, unfortunately, some ladies that had a amniotic fluid embolism.
Oh,
When they were doing a C-section or delivery, and
Yeah.
we've saved them.
Oh, wow.
And we have a survivals reunion once a year, and they all come. And
Oh, wow.
I didn't want to put those pictures for HIPAA things, but
Yeah.
they all come in. And we have great success. And I think initially the OBGYNs were kind of hesitant, and now they're one of the biggest
Oh, really?
advocates we have.
Well, I think we touched on about everything. Thank you guys
Yeah.
very
No,
much.
thank you for
Yeah,
having
thank
us.
you.
Yeah.
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 Really appreciate it. This has been an episode of the PCHD EMS podcast. Thank you for joining us.